Ann Lowe from the Lowdown on Cancer. I'm very, very excited and honored to have a guest today that I think you guys are all going to really, really enjoy, Dr. Rachna Shroff. And I would love to be able to just say I memorized her bio and that, but it's so extensive and impressive that I actually have not. So I'm going to read a little bit about her bio. So here we go. Dr. Shroff is an associate professor of medicine and chief of GI medical oncology at the University of Arizona Cancer Center. And she also serves as the director of the U of A Cancer Center Clinical Trials Office and as the vice chair of clinical research for the Department of Medicine. Dr. Shroff came to the U of A Cancer Center from MD Anderson Cancer Center in Houston, Texas, where she served as faculty from 2010 to 2018 after completing her medical oncology fellowship there. Now, I could quite literally go on for several more minutes as her expertise in pancreatic and biliary cancers has her on many boards, has her speak all over the world. But in order to get to the good stuff and honor Dr. Shroff's schedule, we'll jump right in. So thank you, Dr. Shroff, for sitting with us today. And if you would, share a little bit about your backstory.
Sure, and thank you so much for having me. It's such a delight to be here and to speak with you. So my backstory, actually, ironically, is while I live in Tucson, Arizona, my life has kind of come full circle in the sense of I grew up here in Tucson and left after high school, after I graduated from high school. And the irony of, your teenage years, I said, all right, peace, never coming back. And other than, of course, to visit my parents who still live here. But ironically, a job offer came in 2018 that would enable career development, but also allow me to be closer to my aging parents and have my kids have access to their grandparents, which, until you become a mother, you don't realize the value of. So, but yeah, so it's nice to be back home, essentially, in Tucson, and to be at the University of Arizona, where my father was on faculty for 35 years. And, I did research as a high school student in the cancer center. So it's a really nice story.
Did you always want to be a doctor?
I think I always knew medicine was interesting, and that's really because my mother is a retired nephrologist. She was a physician in private practice and was a kidney specialist. And so I saw her work, 7 days a week back in private practice days. And I loved science. I loved biology and chemistry and such in high school. And as I mentioned, I did lab research as early as high school. So I knew that there was something in there driving me towards it. But I think I look back now and I recognize that I think I was actually always being pulled towards the field of oncology because I did cancer research when I was in high school, and then I was a biochemistry major in college. And I think the reason I chose biochemistry is I loved the signaling pathways, all the pathways that basically drive cell growth, which, as we know, it's that aberrant signaling that leads to cancer cell development. And so, it was kind of that biochemistry going into my love for internal medicine and then taking care of oncology patients while I was in medical school and thinking, wow, this is like the perfect blend of that science, but also that kind of humanistic aspect of medicine that really drives me to do this field.
Did you ever consider any other specialty? I mean, there's so many different specialties and subspecialties. Did you ever consider anything other than oncology?
I think that I like, for instance, I did a residency at Washington University in St. Louis, which is a fantastic place to train. And it's world renowned for a lot of different specialties, but their cardiology, their critical care, pulmonary, those are all really strong fields. And I'm the type of personality who thrives and does not crack under pressure. So I had a lot of people telling me that maybe I should think about cardiology or critical care, ICU, that sort of thing. But even then I was doing research and I, at that time, I thought I wanted to do bone marrow transplant and, take care of leukemia and lymphoma. And that was where I was doing that's the research I was doing. But even then it was, while I enjoyed those the critically ill patients, which is what leukemia patients are, it was really the oncology side of it that kept me going. So I don't know that I considered anything seriously outside of oncology.
Well, great. Thank you for sharing that. Someone in our community asked, what exactly is remission? Does it mean that the cancer is gone, it's resting? So, because that's really what we're discussing today is recurrence.
So remission is it's such a tough word to define, because at the end of the day, remission, I think, means very different things depending on the type of cancer. And, for instance, in the world of GI cancers, to me, remission almost doesn't sound enough. I want to be able to say cure, right? And so there's a fine line between that. And, I think there are certain cancers in which we talk about remission, for instance, malignant hematology, like lymphoma and leukemia and such, where we say, okay, you've had your basically curative or ablative chemotherapy and you are now in remission. And that sense of remission basically means that we have eliminated all sense of visible cancer, but we are going to continue to monitor you, because there's a possibility that 6 months, 9 months, 10 months, 10 years down the line, something could come back. And so the idea of remission, I think, to me, implies a chance that the cancer can come back.
What defines recurrence?
Recurrence is basically defined, again, as the reemergence or seeing cancer again. Now, seeing can be palpably, a melanoma that comes back on your skin, or a mass in your breast that comes back. But recurrence can also be seeing something on imaging, which is typically what we think of and what we see, or is, a CT scan that shows a new mass in the liver or a new mass in another organ. In the world of, again, like malignant hematology, so blood-based cancers like leukemia, lymphoma, sometimes that recurrence is seen on a bone marrow biopsy, and sometimes it's seen in a simple blood draw where we take peripheral blood and send it off for what we call cytogenetics and flow, where we basically pull out in the blood the cancer cells. So recurrence basically has different ways of showing up, but it's basically cancer that has come back.
Does recurrence differ based upon the cancer?
It does. And, the implications for recurrence differ based on the cancer. So, in the world of pancreas cancer, the reason I like to talk about curative treatment is because we know that, unfortunately, if the cancer recurs, it's a lot harder to describe curative treatments. But then there are some cancers where, like such as lymphoma, where recurrence does not necessarily signify some sort of a, oh my gosh, this is it, we're at the end of the line, because there are usually chemotherapies that can be used to send it hopefully back into remission, as we say. Or even breast cancer, for instance, where recurrence, because there's so many new treatments and opportunities for attacking these cancers, remission and recurrence and these types of things don't have the same gravitas as other types of cancers.
Do we know how recurrence occurs?
That's a great question. And, I think at the end of the day, if we could truly scientifically figure that out, we would be able to prevent recurrence. But what we think we understand is, at the end of the day, cancers arise from what we call the cancer stem cell. So these are what we think of as cells of origin, originator cells. So when we think of stem cells, for instance, they talk about embryonic stem cells. These are the cells that lead to the growth of embryos that then lead to the development of a fetus. Similarly, when we talk about the cancer stem cell, which is still a bit of an enigma, we talk about a very specific cell that led to the 1 to 2 cells leading to that mass, leading to that tumor that we physically see on imaging or that we can palpate. And it's those cancer stem cells that we have found to be notoriously resistant to our treatments. So the thought is that when recurrence happens, it's because whatever surgical, chemotherapy, immunotherapy treatments were used, we were not able to truly ablate, eliminate, destroy that cancer stem cell. And so while they may lay dormant for a little while, when given the opportunity, those cancer stem cells have the potential to lead to reaccumulation, if you will, of cancer cells.
Earlier in the week, I interviewed somebody from our community who, it still is just amazing to me, has had 4 cancer recurrences.
Wow.
Does recurrence increase the chance of metastasis?
It can, and again, this is where the distinctions between the cancers kind of come in. So, like I mentioned, there are some cancers that the recurrence that is seen is typically a metastasis. So it's the idea, like I said, in the pancreas cancer world, of a pancreatic cancer stem cell that escaped the surgical knife and escaped the post-operative chemo, but then went through the bloodstream and lodged itself in the liver, and then had the opportunity to grow in the liver. And so when we define that, when we think about that recurrence, we basically talk about that recurrence being a metastatic recurrence. But there are some people who unfortunately present de novo at the time of diagnosis with metastases. So those are obviously not recurrences that are metastatic. Those are just unfortunately metastatic at the time of diagnosis.
I've read from several different sources that recurrence rate, yes, they vary widely depending on the cancers, but that recurrence is roughly 70%. How accurate is that information?
That's probably, unfortunately, close to accurate. I wouldn't say that it's. I think we're doing better. So that's my short answer. I think the recurrence rates get skewed by the fact that the more common cancers, unfortunately, some of them have high recurrence rates. So lung cancer being one of the more common cancers, surgically operable lung cancers, depending on stage, there are high risks of recurrence there. And so when you have millions of cases a year and, globally, that's going to skew that recurrence, the global recurrence rate of cancer. Same thing with pancreas cancer, high recurrence rate. But there are absolutely distinct types of tumors where the recurrence rates are very low. And so, early stage colon cancer, we've absolutely changed the face of early stage colon cancer, and recurrence rates are much lower than they used to be. Same thing with lymphoma, same thing with breast cancer. And so, I think to lump them all together and look at a recurrence rate, I mean, if I was a patient, that would leave a huge lump in my throat. So, I think it's important there again to think about the distinct tumor. The other thing, and this is probably because as an oncologist, you have to be a glass half full kind of personality. But, the other thing that I always tell my patients are statistics. And, if you're cured, you're cured. And it doesn't matter that 80% of the people recur, you're 100% cured. And so I think that's an important thing to kind of keep in mind.
Maybe this is a misconception on my part, but it seems like those that recur usually don't receive the same treatment that they originally had. Is that a misconception on my part? Do they get the same medications? Do they get something different? Is there a whole new plan figured out for them? Help me with that misconception on my part.
So I think a lot of that depends on what we call the disease-free interval. So patients who undergo curative treatment for their breast cancer and then remain in remission or cured for 2 years, 3 years, 4 years, oftentimes there we think it would be okay to utilize and use the types of treatments that were the chemotherapies or whatever that were given previously. The concern is usually when recurrence happens quickly, because when recurrence happens within, like, for instance, the 6-month window is what we use a lot in GI cancers. So in somebody who got post-operative chemotherapy after a colon cancer surgery for 6 months, where we give what we call adjuvant therapy to try to decrease the risk of recurrence, and then usually within, or not usually, but if a patient recurs within 6 months of completing that treatment, then you worry that those cancer stem cells that I was mentioning are resistant to the chemotherapy we gave. So in those situations, it's not wise probably to go back to that treatment. And we should absolutely come up with a different cocktail or a different approach. So I think a lot of it depends on that window, that what we call disease-free interval, that determines how we approach it.
Why do you think that that isn't done more frequently with every cancer? Is it just not standard of care? I mean, why isn't there more genomic investigation done with a cancer case right at diagnosis?
I think it's evolving. I think about a disease that I treat, which is called cholangiocarcinoma or biliary cancers, and it's a rare malignancy. And when I started treating this disease 10 years ago, we didn't know anything about the molecular landscape of this tumor. And through the utilization of next generation sequencing and all these genomic platforms, now we understand that 30 to 40% of patients with cholangiocarcinoma have targetable alterations. And so now we absolutely, people, at least in major cancer centers, know that a patient who comes in with cholangiocarcinoma should have molecular profiling done at the time of diagnosis. But it's unfortunately just a slow uptick. When you look at the lung cancer world, where they use all kinds of different targeted therapies and immunotherapies, apparently there was a national survey done that looked at just kind of all-comer oncologists, and it's still at around 15% that patients are getting molecular profiling done. So I think a lot of it relies on education. It relies on drug availability. A lot of people say, well, these are expensive processes, and if I don't have a drug available for a patient, what is the point, if you will? I'm not saying that's right, but that's how people think. And until recently, a lot of these platforms for profiling and genomics and such were not covered by insurance, and they're, thousands of dollars. So at the end of the day, it's an expense for the patient. And if there isn't a potential drug, something attached to it in terms of treatment, that's really hard to look a patient in the eyes and say, all right, well, I'm going to go try to do your molecular profiling. You may have to pay for it, and I may not even have a drug to offer at the end of it. So, but I think, like I said, I think that's changing. I think we're starting to see a change towards it becoming more of a standard practice.
Everyone in oncology, or certainly my experience of it, talks about the 5-year mark. What's so special about the 5-year mark?
It's funny. A patient asked me that the other day. I will be frank. I don't fully know. What I will tell you is when you look at the tail on the curve, as we call it, so survival curves across the board, most cancers, and this is one of the rare times that you can group everyone together, most survival curves kind of flatten, if you will, at around 5 years. Now, whether that's just because there's a bias inherent in that we kind of have not stopped following, but we don't collect data beyond 5 years. I mean, it's hard to know if some of that is a misunderstanding of how we look at data. But most patients, we have found that recurrence rate, as we call it, that significantly drops off at the 5-year mark across the board, across cancers.
Are there things that doctors can do to help prevent recurrence?
So there's the immediate things that we do. Most patients receive, depending on the types of tumors, if they undergo some sort of curative treatment, whether that be a surgery or something like that, more often than not, there's a role for things like post-operative or what we call adjuvant treatment. So after a surgical removal of a lung cancer, we give post-operative chemotherapy to kind of, what I always describe it as to my patients is there may be microscopic cells that were left behind, eliminating those microscopic cells and hopefully destroying those cancer stem cells. That's immediately what is typically done. Now, in terms of more long-term prevention, there's a lot of data now trying to understand the role of diet, exercise, those types of things. Like there is a fair amount of data that's substantiated that by having a diet low with kind of lower amounts of red meat, increased exercise decreases your risk of breast cancer, lung cancer, and colon cancer recurrence. Diets rich in leafy greens and fruits and vegetables as opposed to like a very meat heavy diet. But what I tell my patients is that would be my recommendation for you anyways. So it's hard to know sometimes, whether that's just patients saying, I want to take better care of myself and that sort of thing, or if that's an intervention, as we want to call it. But so those are kind of where most of the data is focused on to date. There's a lot of things happening in what we call the chemo prevention space. The the hallmark of that, of course, would be the tamoxifen story after, breast cancer. But there's a lot of other tumors, a lot of different types of tumors that are looking at things like that. A pill, is there a pill we can take every day to decrease the risk of something coming back? And that's a really active space for research right now.
As you say, I've met people that, drank like a fish, smoked cigarettes like crazy, and ate horribly and never had a recurrence. And I've met people that did it, if you want to say there's a perfect way to do it, but did it perfectly, plant-based diet, exercised every day, didn't smoke, didn't drink, didn't do any of those things, and still had a recurrence. Why is that?
I completely hear you. And I will say, as an oncologist and as a daughter to a cancer survivor, nothing is more frustrating than not knowing the answer to that question. I mean, I say this all the time that, the risk factors, even in developing cancer, let alone recurrence of cancer, there are people who do everything right and still get lung cancer. They don't pick up a cigarette ever and they still get lung cancer. And so much of that goes back to, again, what, not to keep harping on it, but it's got to be something in the genomics, in the mutations. There's mutations that we inherit, and then there's mutations that we acquire over the arc of our life. Those are the somatic mutations. And for some reason, some sort of environmental interaction with the patient's genetic makeup, I think, predisposes people to recurrence and or development of cancer. And we just haven't unlocked that yet.
My own experience and that of so many people that I talk with is, get this monster out of me as soon as possible. How long is too long to wait? And how much will the cancer spread while I'm waiting for treatment?
Again, that is so dependent on the type of tumor. But what I would say is, and this is what I tell most of my patients is, a month, 2 months, probably okay in the arc. Now, that being said, a month or 2 months probably feels like an eternity to the cancer patient, but probably okay.
If I'm not mistaken, I heard you say that you were personally impacted by cancer. How so?
My mother actually had lung cancer. I was still living in Houston at the time, but she was here in Tucson. And, she was, speaking to what you said, she was your classic, never picked up a cigarette, non-smoking Asian female. We know that there is a small subset of lung cancer that is found in Asian females who are never smokers. And, you learn about it in medical school and you learn about it in residency, and you never think it's going to be your Asian non-smoking female mother. But, we were very blessed that she happened to notice that she coughed up a little bit of blood, which is so actually very rare, frankly, with lung cancer. And her being, having a medical background, was smart enough to get a chest x-ray and found a mass. And I will say, I did not a podcast, but an interview for ASCO, the American Society of Clinical Oncology, their philanthropy organization, the Conquer Cancer Foundation, where I talked about being on the other side, like not sitting on the doctor's chair, but sitting in the exam room with my mother. And I will say I did not handle it very well. I mean, my poor husband told me that she had a mass in her lung, and I was holding our newborn son and I almost dropped him. I was so shocked. And I basically got on a plane and I picked her up and I brought her to Houston because I knew that I would have control over what was happening if it happened in my hospital. And so she was thankfully early stage and was able to undergo surgery and postoperative chemo, and has been now more than 7 years out from her diagnosis. But at the end of the day, I said in this interview that I did that it completely changes your perspective, because she got a postoperative chemotherapy that I give all the time, and the chemo teaching, there's a risk of what we call ototoxicity, a hearing loss, tinnitus, like ringing in your ears and hearing loss. And as a physician, I would always kind of downplay it and say, well, like that's really rare. We don't really see it. My mom got 1 dose of the chemotherapy and lost her hearing. And so she's got hearing aids. But, after having that experience, I was like, okay, I need to not downplay this to our patients, because that's a big deal. And, you know, while it might be a rare thing, if it happens to you, it's a huge quality of life thing, you know? So it was good. It was for me, I think it helped. I hope it helped me be a more empathic oncologist.
We've covered a lot of ground, and I want to respect your time as well. Is there anything else you'd like to share with us, or something, you know, advice for our community, anything that you'd like to share in reference to recurrence or even about clinical trials?
I think the most important thing that I think is important for patients to know is that, as scary as the word recurrence, well, cancer for sure, but recurrence even more so, is, you know, don't lose faith. Don't give up on hope. You know, I say all the time, I don't have a study that I can print out and show you, but I truly believe that there's a mind over matter component to cancer care and to treatment. And I really can't emphasize enough the importance of being open and verbal and communicating your wants, needs, and desires with your oncologist. It is our job to hear that, to understand your goals of care. And it is our job to work with you on those goals, because some person's goal may be, you know, I want to live forever. And some person's goal may be, I just need to be able to continue playing piano during my treatment. And those are both equally important goals. And so expressing those and verbalizing those are really important. And then I have to believe that it's really important to be, you know, if you don't feel that you're getting your voice heard, you know, tertiary care cancer centers are really, I mean, they're comprehensive cancer centers for a reason. There's a multidisciplinary team, there's tumor boards, there's molecular tumor boards where genomics and personalized medicine plays an important role. And of course, clinical trials. And, you know, don't, like we said earlier, you know, clinical trials are your friend. They're not a bad word. We don't do a lot of placebo trials in this country where you get a sugar pill. So if you have questions about those things, ask your oncologist, inform yourself, and make sure that you're at a place where they're offering trials and they're able to kind of discuss with you where the novel treatments are moving, so that you can feel that you're getting that cutting edge care.
I just want to thank you very, very much for taking time out of what I know is a very busy schedule between oncology and being a mom. So I just want to thank you. Thank you for sharing the information. I think this is going to clear up a lot of questions for a lot of our community. And I just really, really appreciate your time and respect what you're doing in regards to research and clinical trials. And I'm so glad we have you here in Arizona.
Thank you. Thank you so much for having me. It was so, you're incredibly easy to talk to. So I was happy to chat.
Thank you for watching the Lowdown on Cancer presented by the Cancer Fund. To learn more about what's coming in future episodes, visit us at www.cancerfund.com. While you're there, check out past episodes and be sure to click join us to become a member of the Cancer Fund community. As a member of the community, you'll receive early access to new interviews, as well as other announcements. Make sure to connect to all of our social media channels so you don't miss a thing. In addition to getting early access to new episodes of the Lowdown on Cancer, Cancer Fund members play a critical role in driving cancer innovation forward, so that one day we can more than hope. We can actually beat cancer. Thank you for joining us on this journey.